In medicine, there are findings that close a diagnosis the moment they appear. A pediatrician examining a feverish, coughing child notices Koplik spots, those tiny grains of salt scattered across the inner cheek, and the diagnosis is settled: measles. No serology required, no further test, no further discussion. A neuropathologist examining brain tissue finds Negri bodies in a Purkinje cell, and the diagnosis is settled: rabies. The verdict is in. These are the pathognomonic findings. Single signs, so specific to a single disease, alone confirms it. They are the closest thing medicine has to a smoking gun pulled directly from the hand of the suspect. Psychiatry has none of this. Not one symptom, not one behavior, not one pattern of thought, not one neuroimaging signature is, on its own, sufficient to confirm the presence of a mental illness. Pick any phenomenon in the catalogue of psychiatric concerns, and you can produce a counterexample, a cultural exception, an evolutionary rationale, when an entirely sane person can present this manifestation without earning them a diagnostic label and a prescription. This is not a small feature of psychiatry. It is the central fact of psychiatry. And for clinicians, for trainees, for educated patients, and for broader public that consumes psychiatric ideas without always understanding their foundation, it is worth dwelling on. Begin with hallucinations. Auditory hallucinations in particular, voices, internal speech that is not the patient's own, perceived as external, are presented to medical students and psychiatric residents as cardinal phenomena of severe mental illness: schizophrenia, schizoaffective disorder, psychotic depression. The textbooks list them, the boards examine them, the clinic identifies them. And yet across human history, hearing voices has been the cause not of disability but authority. Moses heard a voice on Mount Sinai. Mohammed heard a voice in the cave of Hira. Joan of Arc heard the voices of St. Michael, St. Catherine, St. Margaret in her father's garden. Saint Teresa of Avila described elaborate auditory experiences during prayer. Hildegard of Bingen, the 12th century Benedictine abbess, composer and natural philosopher, attributed her entire body of work to voices and visions she received from a divine source. Step outside the Abrahamic tradition, and a pattern repeats itself with increased frequency. The shamans of Siberia, the medicine men of North American plains, the witch doctors of West Africa, the curanderos of the Andes, the oracle priestess of Delphi, the seers of Norse society, all of them communicated with entities that were, by any modern definition, hallucinatory. And the response of their societies was not to medicate them. It was to seat them at the council, to consult them on matters of war and harvest and migration, to follow them. The phenomenon was identical to what now appears in a clinical interview. The interpretation was opposite. Even within ordinary secular 21st century life, hallucinations are far more common in healthy people than the textbooks suggest. Bereavement hallucinations, hearing the voice of a deceased spouse, glimpsing them across a room, sensing their presence in a familiar chair, are reported by something between 30 and 60% of widows and widowers. And they are not pathological, they are part of grief. Hypnagogic hallucinations, occurring at the threshold of sleep, are reported by a substantial fraction of general population, all of whom go on to live entirely ordinary lives. Sensory deprivation produces vivid hallucinations in healthy volunteers within hours. The phenomenon is on a spectrum, and the line between mystical experiences and normal grief, neurological quirk, and psychiatric disorder is not drawn by the phenomenon itself, it is drawn by us. Consider next suicide. The deliberate ending of one's own life is, by every modern psychiatric framework, a marker of severe pathology, and rightly so when it appears in the context of depression, psychosis, or untreated despair. But strip the act of its psychiatric context and consider it as a behavior in isolation. Imagine a particular scene. You are a father. You are on the deck of a ship in the middle of a hurricane, somewhere in the open Atlantic. The sea is the color of hell. The wind is screaming at you. A wave breaches the rail and sweeps your 5-year-old daughter off the deck into the water. You can hear her for 1 second, then you cannot. What do? Do you sit calmly on the deck, weighing the actuarial probability of your survival? Conclude that since the odds of you both drowning are something like 99%, the rational course of action is to remain on the ship? Or do you jump? Of course you jump. Every father jumps. And if anyone in the aftermath of the decision, supposing you survived to discuss it, were to suggest that the act of voluntarily entering a hurricane sea with full knowledge of near certain death constituted a manifestation of psychiatric disturbances, that person would be themselves regarded as a disturbed one. The behavior in pure mechanical terms, voluntary action knowing it carries near certain death, is indistinguishable from suicide. But in a certain context, it is the highest expression of love a human being is capable of. The behavior is identical. The interpretation is opposite. Maximilian Kolbe walked into a starvation bunker at Auschwitz to take the place of a stranger. We do not call him a mentally ill person. We call him a saint. The capacity of human beings to give up their lives for children, for comrades, for ideas, for strangers is not a glitch in our cognition. It is one of the things that makes us recognizable to ourselves as moral creatures. Let's move next to the autistic spectrum. There is perhaps no contemporary psychiatric category whose boundaries are more contested, whose criteria have shifted dramatically across editions of the diagnostic manual, and whose presence has been retroactively attributed to so many luminaries of human history. Take Isaac Newton. He never married. He died, by most accounts, a virgin. He was profoundly solitary, with very few close friends, and the friendships he did have ended in spectacular and lasting feuds with Robert Hooke, with Gottfried Leibniz, with John Flamsteed, with anyone who dared to challenge him on a question of natural philosophy or priority. He could become so absorbed in his work that he would forget to eat for days, forget to sleep, forget to leave his room in Trinity College for weeks at a time. His servants would find his meals untouched on the tray and remove them. His friends recounted that he would walk into rooms on errands he had forgotten at the moment he entered, stand still in the middle of the floor for several minutes, then turn around and leave. Newton pursued obsessive special interest far outside his stated profession. He devoted years to alchemy research, accumulating roughly 1 million words of alchemy notes, more than he wrote on physics. He devoted further years to biblical chronology, calculating from scriptural genealogies that the world has been created in 4000 BC, and producing detailed dissertations of the prophecies of Daniel and the book of Revelation. He once stuck a bodkin, a long blunt needle, between his eyeball and the bone of his eye socket, pressing to the back of his eye to investigate the patterns of color and light that resulted, and recorded his observations dispassionately. The pattern, whatever you wish to call it, is striking and consistent. We do not need to render posthumous diagnosis to recognize that the man who founded classical mechanics did not function the way most of the contemporaries functioned, and that the very intensity of his cognitive style was inseparable from the magnitude of his contribution. And then there was Henry Cavendish, the 18th century English chemist and natural philosopher who isolated hydrogen, who measured the density of the earth, who outdid even Newton in social discomfort. Cavendish could not bear the presence of others. He could not look people in the eye. His voice, when he spoke at all, was described by contemporaries as a thin, hesitant cry, often delivered while he stared at the floor or the corner of the room. He communicated with his housekeeper in writing, leaving notes on the hall table specifying what he would like for dinner, because the act of speaking aloud to her day after day was beyond him. He had a back staircase installed in his London home so that he could move between rooms without the risk of encountering a female servant on the main stair, an encounter he found unbearable. His scientific habits matched his domestic ones. He attended Royal Society meetings, but stood in the doorway hovering, ready to flee. He did not publish much of his work. Vast quantities of his electrical experiments, anticipating the discoveries of Coulomb and Ohm by decades, sat unpublished in his desk and were discovered only after his death by James Clerk Maxwell. The most famous Cavendish anecdote concerns a Royal Society dinner at which Dr. Jan Ingenhaus, the Austrian-born physician and discoverer of photosynthesis, brought along a young Austrian admirer of Cavendish to introduce him. The young man, in the manner of admirers everywhere, launched into an effusive tribute, praising Cavendish for a contribution to science, expressing his wonder at being in his presence. Cavendish stood frozen. He stared at the floor. He waited as long as politeness demanded, and then, mid-sentence, he turned away, walking rapidly to the door, descended the stairs, climbed into his carriage, and went home, leaving the bewildered Austrian holding the unfinished half of his tribute in the air. The neurologist Overly Sachs, writing 2 centuries later, made a strong case that Cavendish met every criteria for what we now call autistic spectrum disorder. He functioned, he produced, he measured the earth. He simply could not be in the same room with another human being for more than few minutes. Let's move now to ADHD, where the picture grows even more interesting. The frequency of attention deficit hyperactivity disorder and of the genetic variants associated with it is not evenly distributed across the human population. There is a documented gradient. As you move outward from East Africa, the cradle of our species, along the great migration routes that took our ancestors across Eurasia, across the Bering Land Bridge, into the Americas, roughly 15 to 20,000 years ago, during the last glacial maximum, and then southward through the Americas, the prevalence of certain ADHD-associated genetic variants rises. The most studied of these is the 7-repeat allele of the DRD4 dopamine receptor gene, the so-called 7R variant, which is associated with novelty seeking, with risk tolerance, with reduced inhibitory control, and with elevated rates of ADHD diagnosis. In a landmark paper published in 1999 in the journal Evolution of Human Behavior, Chuansheng Chen and his colleague at the University of California, Irvine, Michael Burton, Ellen Greenberger, and Julia Dmitrieva, demonstrated a statistical correlation between the historical migration distance of a population from its African origin and the frequency of the 7R allele in that population. The further from East Africa a population had migrated, the more 7R alleles it carried. The peak frequency was observed in indigenous populations near the southern tip of South America. The descendants of those who had crossed Beringia traveled the entire length of 2 continents and reached Tierra del Fuego, the geographical terminus of human migration on the planet. The interpretation, advanced by Chen and refined by subsequent researchers, including Dan Eisenberg, who studied the Arial pastoralists of northern Kenya, and found that the same 7R allele was associated with better nutritional outcomes in nomadic Arial, but worse outcomes in their recently settled cousins, is straightforward. The settlers who pushed deepest into unknown were not the contented ones. They were not people who looked at a fertile valley and thought, "This will do for me and my children." They were the restless ones, the novelty-seeking ones, the ones who could not stand still, the ones who wanted the next thing, the further thing, the thing over the horizon, the ones who were temperamentally incapable of being satisfied with what they already had. The descendants of those people concentrated at the geographic terminus of the longest human migration in history and carry the genetic legacy of that restlessness in higher proportion than the general population. What we now diagnose, medicate, and accommodate as a disorder of attention and self-regulation was 10,000 years ago the trait that carried families across 2 continents. The dopaminergic profile that makes a 4th grader unable to sit through a 45-minute lesson in arithmetic is a close relative of the dopaminergic profile that took someone's distant ancestor from the Yukon River Basin to the Strait of Magellan on foot with stone tools across glaciers and rainforests and Andean passes. The disorder of one century is the engine of another. Now, hypomania. The hypomanic individual is described in our textbooks as someone whose mood is elevated, whose energy is excessive, whose speech is rapid and pressured, whose ideas come faster than the tongue can deliver them, who needs less sleep than ordinary mortals, who jumps from one project to another, who is convinced of their own capacities to a degree that strikes others as grandiose, who tolerates risk that would paralyze the ordinary people. Read that description again, slowly, and ask yourself how many highly successful entrepreneurs and founders you have read about, listened to, or worked for whose published biographies do not match it almost word for word. The man who is on at 4 in the morning and on at midnight, the woman whose mind generates 12 ideas in the time you generate 1, 8 of which are bad, 2 of which are good, and 2 of which will change an industry. The founder who sleeps 4 hours, who reads 3 books a week, who terrifies a board of directors with the velocity of his thinking, who replies to emails at all hours, who is always 1 step ahead in the meetings because his cognition simply runs at a higher clock speed than the room. The technology founder who restructures an industry by the age of 30, the financier who sees 7 moves ahead on a chessboard everyone else is still setting up. By any list of hypomanic traits, these people do qualify. But what does not qualify them for a diagnostic label, it is the absence of 2 specific items: impairment and subjective distress. They are not suffering, they are not failing to function. They are in fact building empires, raising capital, hiring teams, and changing the shape of global commerce. The traits are identical to those listed in the diagnostic manual. The clinical verdict is opposite, because the only thing that distinguishes a diagnosis from a temperament in this case is whether the trait helps or hinders the life the person is living. A 4 in the morning founder is a hero. A 4 in the morning unemployed person with the same internal experience is a patient. The phenomenon is identical. The verdict is opposite. And now consider major depression, perhaps the most surprising candidate for evolutionary rehabilitation. To think of depression as pure pathology, an unqualified catastrophe of the mind. And yet evolutionary psychiatrists, beginning with John Price and Russell Gardner, and continuing through the work of Randolph Nesse and others, have argued with considerable force that the depressive response carries adaptive value. The argument is sometimes called the social rank hypothesis. The person who, in a losing fight or a losing competition, slumps, withdraws, signals submission, becomes small, that person survives more likely than the others who continue to fight. The person who fights to the last breath, who refuses to submit, who cannot acknowledge defeat, gets killed. Across the long arc of human prehistory, when conflicts within and between groups are settled with stones, clubs, and spears, the individuals who possessed the capacity to disengage, to surrender, to become small and quiet and unthreatening in the face of overwhelming force, those individuals lived to reproduce. Their genes are in us. The lassitude, the loss of motivation, the social withdrawal, the diminished appetite, the sense of futility that accompanies a depressive episode are, in this view, not random malfunctions of the brain. They are ancient survival programs running in modern minds whose social environments, the office, the family, no longer have any obvious use for the program, and yet the program runs anyway, sometimes against the interests of the person running it. Depression is, in part, what happens when an evolutionary brake is applied to a life that was not, in fact, in mortal danger. Which brings me to my last point. The very definition of mental illness has shifted dramatically across the centuries. And the shift is not a story of pure scientific discovery, of finally seeing what was always there. It is, at least in part, a story of changing context, changing demand, and changing tolerance. Take post-traumatic stress disorder. Trauma has existed as long as humans beings have existed. The Greek hoplites returning from the slaughter at Marathon, the Roman legionnaires who survived Cannae, the English archers as Agincourt, the Union soldier who walked away from the Antietam, all of them surely experienced what we would now recognize as trauma symptoms. And yet, the formal diagnostic category of post-traumatic stress disorder did not exist until 1980, when it was introduced into the third edition of the Diagnostic and Statistical Manual, largely through the advocacy of a clinician treating Vietnam War veterans. Before 1980, the same constellation of symptoms had carried different names. Charles Myers, a British psychologist, coined the term shell shock in a 1915 paper in the Lancet, describing what he was observing in soldiers returning from the Western Front. During the American Civil War, the cardiologist Jacob Mendez da Costa described a syndrome of exhaustion and chest pain in soldiers, which he called irritable heart, and which his colleagues called soldier's heart. After the Second World War, the prevailing term in American psychiatry was combat fatigue. The phenomenon was the same. The names changed. The diagnostic boundaries moved with the politics of the day. ADHD followed a similar trajectory. The English pediatrician George Still, in his Royal College of Physicians lectures in 1902, described a group of children with what he called an abnormal defect of moral control, a description that maps onto contemporary ADHD with uncomfortable precision. And yet, ADHD did not enter the diagnostic manuals as a recognized entity until 1968, when it appeared in the second edition of DSM as a hyperkinetic reaction of childhood. It was renamed Attention Deficit Disorder in 1980 and given its current name, Attention Deficit Hyperactivity Disorder, in 1987. And here we have to be honest about the reason for the change in salience, which is not purely biological. Simpler society, agricultural, pastoral, hunting-gathering, artisanal, placed cognitive demands on their members that were profoundly different from those placed by today's society. The boy who could not stand still through Latin grammar in an 18th century classroom found his way to a farm, to a workshop, to a battlefield, to a deck of a ship. He functioned, he married, he had children, his genes passed on. In the 21st century, his great-grandson finds himself in a fluorescent-lit cubicle, expected to remain attentive to a spreadsheet for 9 consecutive hours, and the same cognitive style that served his ancestors admirably now produces a referral to a psychiatrist and a prescription for a stimulant. The disorder is, in part, a disorder of context. Today's office, today's classroom, today's 12-hour screen-mediated working life, these are environments engineered, often unintentionally, to amplify and to expose the precise cognitive style that earlier societies absorbed without noticing, which is also why these traits, far from being eliminated by selective pressure across the generations, persist throughout the human population in striking proportions. Because in the long arc of our species, they carried clear advantages. They built explorers, they built settlers, they built the people who walked from Beringia to Tierra del Fuego. They built the species that now occupies every continent on Earth and is, at this moment, watching this video. So when a medical student asks you for the pathognomonic sign of a psychiatric illness, the honest answer is that there isn't one. There are clusters, there are patterns, there are contexts, there are degrees of impairment and degrees of distress. There are diagnoses that hold up under scrutiny, and there are diagnoses that dissolve when you challenge the latitude, the century, or the job description. Psychiatry is the only branch of medicine in which the diagnostic question cannot be fully separated from the question of what kind of life the patient is being expected to live, and from the question of what kind of life their society currently considers the default. which is uncomfortable. It is also true. And it is one of the reasons that practicing psychiatry well, as opposed to practicing it in a kind of psychopharmacological housekeeping, requires a deep humility about the categories one is using. If medicine has its smoking gun, psychiatry is a discipline that has to ask every single time, whose hand was on the trigger? What were they aiming at? Whether the room counted as a crime scene at all, and whether the bullet, in some other century, might have been considered a perfectly respectable form of greeting, which is, frankly, why the field is so much more interesting than its critics give it credit to, and so much more dangerous in the hands of people who think it isn't.